Okay, for the lacrimal disorders, we have the famous 50-50 rule. So for the lacrimal lesions, 50% of lacrimal lesions will be tumors, and the 50% of lacrimal gland lesions will be inflammatory in nature. But frankly speaking, the inflammatory diseases or the inflammatory lesions are more common in the clinical practice than 50%. So usually the presence of lacrimal gland lesion is a chronic non-specific inflammation until proved otherwise, unless there are features suggestive of tumors, as we will see later. So for these 50% cases of tumors, they are further subdivided into 50-50. So 50% of these tumors are non-epithelial in origin, and 50% of these tumors are epithelial in origin. We have now again the 50-50 rule in the epithelial. For the epithelial, we have 50% are benign, such as pleomorphic adenoma, and 50% are malignant, such as the adenoid cystic carcinoma. So for the most common tumors in the lacrimal gland are the pleomorphic adenoma and the adenoid cystic carcinoma. So let's review the commonest features of them. For the pleomorphic adenoma, what is called benign mixed tumor, and this name has a reason. These patients usually present with females, middle-aged, present with a gradually, slowly progressive, painless proptosis. The patient usually prescribed as it is a tolerable proptosis. So the patient doesn't have a problem with it, and usually it doesn't complain from the proptosis unless it will cause marked disfigurement or cause diplopia. This by examination, you will find that the eye is displaced down and in. So this means that there is a mass which is up and out, which is the lacrimal gland. The lacrimal gland enlargement. So you will send the patient for radiology. So this is a CT scan showing this mass compressing the globe down and in. And within the context of orbital lesion, we have always to mention and note the relation of the mass to the surrounding structures, specifically the ocular structures and the bone, because sometimes the masses can cause molding of the bone, as you can see here. So there is a molding of the bone is bowing, but it is not infiltrated. There is no bone erosions nor calcification. So this is just molding of the bone and with normal surrounding ocular structure. So the treatment for this mass is by excision. So excision of this mass will show the characteristic features of being pleomorphic. Pleomorphic meaning that there is different elements within the tumor. You may find the myoepithelial cells, you may find the mesenchymal matrix, you find epithelial elements. So the tumor is mixed or heterogeneous. However, it is benign. So this tumor doesn't cause invasion to surrounding structures and doesn't cause metastasis. However, there is important surgical rule for this tumor is to not incise biopsy it. So when you are excising this mass, you excise it in toto, meaning that you excise the mass as a whole and not do incise biopsy from the mass if the clinical feature suggestive of pleomorphic adenoma. Because if you did so, there is higher risk of recurrence and malignant transformation into adenoid cystic carcinoma. So for adenoid cystic carcinoma, patients are old, about 40 to 50 years old, presenting with rapid progressive onset of proptosis, downward and in dystopia, and severe pain, because this lesion, when imaging done, you can see that there is bone erosion. Compare the lateral orbital wall here to the lateral orbital wall at the side of the lesion. You can find that there is hyperostosis. Again, compare the thickness of the lateral wall to the thickness here. There is hyperostosis, there is bone erosions, and this bone erosion that will cause the patient this severe pain. So a biopsy from the lesion will show the presence of characteristic Swiss cheese pattern. So you will find masses of cells. These mass of cells have pools of mucin, which corresponding to the pattern of a Swiss cheese. This disease has a very poor prognosis and very high morbidity and mortality, and the treatment for this condition will be by radiotherapy and chemotherapy. So now we come to the orbital disorders. For the orbital disorders, we have to consider two important factors. First of all, the age. So if you have a patient who have a proptosis, and you should never miss the age of the patient and the course of the disease, because the age can give you a clue about the diagnosis, as it is can be either in some tumors are present in children, others are present in adults. For example, for children, we have the dermoid cyst. For the capillary hemangioma and lymphangioma are present in the children, in contrary to cavernous hemangioma or hemangiopericytoma, which is a tumor arising from the pericytes lining of the capillary walls. Also, the neurofibroma, plexiform neurofibroma, and the optic nerve glioma are typically occur in the first 10 years old, while in adults, the schwannoma and optic nerve meningioma occur more in the middle age. It could be mesenchymal, such as rhabdomyosarcoma, or a tumor arising from the rhabdomyoblast, or fibrous histiocytoma, which is a tumor of bones causing what's called ground glass appearance, as we will see later. It can be also other tumors, such as metastasis, as a neuroblastoma is the commonest metastatic tumor for children, or for the adults. The commonest metastatic tumor to the orbit arise from the lungs in males and breasts in females. Also, epithelial tumors, as we see before, is the pleomorphic adenoma and the adenoid cystic carcinoma are more common in the adult age group. So this is for the age. For the course, we will now identify each tumor, and the course of each one is also can give you a clue about the diagnosis. For example, the orbital lymphangioma. So the orbital lymphangioma will cause a bluish mass. This bluish mass is may cause proptosis, but it is slowly progressive and usually doesn't cause any problems to the patient. If you did histopathological examination, you will find there is a proliferation of lymphatic channels. However, sometimes this patient can develop rapid proptosis even within 1 hour. Rapidly progressive proptosis and the pain and the presence of hemorrhagic swelling like this, then you may suspect the presence of chocolate cyst. Chocolate cyst meaning that there is a hemorrhage inside the orbital lymphangioma. So when you order imaging, you will find there is a hemorrhage, and this hemorrhage is caused by the presence of intralesional bleeding inside the lymphangioma, which is called chocolate cyst, and treatment is by just aspiration of this blood. So just remember, acute painful proptosis in the setting of orbital lymphangioma can be due to intralesional hemorrhage or what's called chocolate cyst. Another tumor which is very common with cases of neurofibromatosis type 1 is called optic nerve glioma. So for the optic nerve glioma, it will cause proptosis, axial proptosis, usually within the first 10 years of life. Then these patients, at the time of diagnosis, we usually will present with visual acuity loss, as this tumor will cause visual acuity loss followed by proptosis. So this tumor, when you are suspecting this tumor, you have to do two things. First, look for other features of NF1, and the next one is to check for the imaging. And so the imaging, as you can find here in the T1 and T2 MRI, there is a fusiform swelling in the orbit. So this fusiform swelling is consistent with the optic nerve glioma. So here is a question: what shall we do with this optic nerve glioma? The radiological or the radiology here or the imaging carry an important prognostic value here, because sometimes it will show that the tumor is small, localized within the orbit, and there is no progressive enlargement. So as long as it doesn't cause much proptosis with no exposure keratopathy, for example, so the treatment will be observation. However, if we find that there is a tumor show intracranial extension causing optic nerve glioma, so we may consider to either surgical excision through intracranial approach to prevent the chiasmal involvement, or if it is near to the chiasma, we may consider radiation to stop the progression of this tumor. So this tumor is due to, if we are not sure of the diagnosis, we can take a specimen for histopathological examination, and it will show there is a proliferation of glial tissue. So the glial tissue of the optic nerve include many cells like astrocytes, oligodendrocytes. So this is a tumor of astrocytes. It is called pilocytic astrocytoma. It's more commonly to be the benign nature of which is the optic nerve glioma, which is that the common in the young age group and more benign in nature. This is in contrary to the malignant nature, which is the glioblastoma multiforme. In glioblastoma multiforme, it will cause rapid mortality within 6 months to 12 months. So, but this is not the case here. Another important histopathological feature in case of optic nerve glioma is called Rosenthal fibers. So Rosenthal fibers is the presence here. It is a characteristic feature for optic nerve glioma. So again, remember, this is present with a gradual swelling or gradual proptosis. It's in the young age. For the optic nerve sheath meningioma, it can present also with a gradual proptosis, but it present with the older age group. So it's present in the middle age with gradual proptosis. As you can see here, it is not that noticeable, and it could be either primary or secondary. Primary meaning that the meningioma arise from the dura covering of the optic nerve sheath, so it will causing proptosis. Secondary, it meaning that the meningioma arise from the dural or the meningeal covering of the sphenoidal wing. Here is the sphenoidal wing. So it will lead to increased thickening of the sphenoidal wing, causing pushing of the eye, causing secondary proptosis due to sphenoidal wing meningioma. This tumor are characteristic as we said, present in the middle age. It will present with proptosis and loss of vision, but the proptosis is usually preceding the loss of vision. It is also one of the features of neurofibromatosis. It can be present with optothelial shunts in the optic disc due to chronic optic disc ischemia, and it can also lead to what's called gaze-evoked amaurosis, meaning that the patient will have loss of vision, specific gazes due to compression by the tumor over the optic nerve. Imaging will show the characteristic what's called railroad track sign. So there is diffuse thickening of the optic nerve, not the same like the cylindrical pattern or the fusiform pattern of optic nerve glioma. And the histopathological examination will show proliferation of meningothelial cells and characteristic pattern of Sammuma bodies. So these Sammuma bodies are very suggestive of meningioma. So don't forget that the Rosenthal fibers are suggestive of glioma, while the Sammuma bodies are suggestive of meningioma. So here the sphenoidal wing meningioma. As you can see here, there is enlargement of the sphenoidal wing. There is thickening. There is fullness of the temporal fossa. And if this patient, if this patient, you examine him at the temporal area, you find that this temporal area is thickened caused by bone hyperostosis. Bone hyperostosis, as you can compare the sphenoidal wing here from sphenoidal wing there, you can find there is the marked difference between here and there. And this can also lead to proptosis and the pushing of the globe forward, and they can be diagnosed by imaging. This shouldn't be confused with the fibrous dysplasia. For the fibrous dysplasia, again, it is affection of the sphenoidal wing, sphenoidal bone, or greater wing of sphenoid can be also occur, but there is marked difference between the fibrous dysplasia and the sphenoidal wing. Because in the fibrous dysplasia, there is no laying down of calcium, or there is no laying down of bone. There is just that the bone is replaced by fibro-osseous tissue. So since it is not a true bone, it doesn't show that the hyperdensity of the bone that's present in the sphenoidal wing meningioma. But rather than this, it was present with what's called the ground glass appearance. So it is mottled, it is grayish in color, and not hyperostosis. This can be confusing because both conditions can cause changes in the sphenoidal bone, and both conditions can cause gradually progressive slowing. So the CT scan or the imaging will be differentiating between both of them. Also, if the fibrous dysplasia can be associated with some endocrinological manifestations such as hypogonadism or hypopituitarism, and in such condition, this is called McCune-Albright syndrome. So again, sphenoidal wing meningioma, fibrous dysplasia, even optic nerve meningioma are all present with slowly progressive proptosis. This is very important. Optic nerve schwannoma can occur as a part of neurofibromatosis, specifically neurofibromatosis type 2. It is present in 80% of cases of neurofibromatosis type 2. The patient will present with an orbital mass. Here it is. This orbital mass again can cause proptosis, but the course is very slow, meaning that until it happens, till the patients complain, it may take even about 10 to 15 years. So it is very slowly progressive. And the patient will present with very slowly progressive proptosis. They will present with this tumor is well circumscribed as and encapsulated, and this tumor present with the middle age. So it is not a tumor of childhood, it's present in the middle age. So this tumor, when excised, so this tumor can be caused by a schwannomin gene, or what's called the Merlin gene, or mutation of this schwannomin gene or Merlin gene, which can occur in neurofibromatosis type 2. So if a patient present with deafness and present with a slowly progressive proptosis, think of neurofibromatosis type 2 and schwannoma. Histopathological examination of this tumor will show the schwannoma or the neurolymphoma show spindle cell tumor. So the tumor cells are spindle in shape and showing either anthony-type A or anthony-type B pattern. Either it is fibrillary matrix or fibrillary matrix in anthony-type A, or myxoid matrix in anthony-type B. So anthony-type A and anthony-type B are specific histopathological types of orbital optic nerve schwannoma. Sometimes the patient present with a tumor elsewhere in the body. Commonly, it is a breast tumor or a breast mass in case of females, or lung tumors in males, and all of a sudden they are present with an orbital mass. So the key word here is the onset again. The onset is for metastatic orbital tumor is the rapid. So for orbital metastasis, they were present with a rapid onset. This is the number one. Number two, presence with inflammation. So they are present with a picture like inflammatory in nature, not tumor in nature. And they can present with an bone changes. These bone changes can either be bone erosion or can be hyperostosis, as in case of prostatic tumors, metastatic prostatic tumors. So these patients can present with bone lesions, such as bone erosion or hyperostosis, present with inflammation, present with rapid onset. And also the fourth feature that's suggestive of metastatic tumor is the presence of multifocality. So multifocality meaning that the tumor is not a single in nature, but it's present as multiple masses. So this means that there are showers of metastasis coming elsewhere from the body that every time localize in the orbit, they will form a colony or form a mass. So they are multifocal or multi-localized in nature. The rule in case of metastatic breast carcinoma is to cause proptosis. However, there is a specific type of breast carcinoma. It's called squamous carcinoma, which characterized by fibrous tissue. So the primary tumor is fibrous tissue, so that the secondary tumor will be a fibrous tissue as well. So metastatic tumor in the orbit will lead to fibrous tissue contraction, causing enophthalmos. So this specific type will not cause proptosis, but will cause enophthalmos instead. Rhabdomyosarcoma, it is the commonest primary orbital tumor in the childhood, causing rapidly progressive proptosis with no pain, no fever, and no leukocytosis. And this has been said more than once to differentiate the rhabdomyosarcoma from the orbital cellulitis. Diagnosis can be made by the histopathology. You will show the rhabdomyoblast and what is called the cross striations, which is a characteristic feature for the rhabdomyosarcoma. So the presence of strap cells or rhabdomyoblast, here is it, and the presence of here is cross striations. There are different pathological features of this tumor. This tumor, in the form of histopathology, can show the embryonal, which is the most common, the pleomorphic, which is the least common but has the best prognosis, as we said before, being a pleomorphic, meaning that it will respond to different modalities of treatment, such as radiotherapy or chemotherapy. And finally, we have the alveolar, which carry the poorest prognosis, and the treatment of this tumor will be surgical debulking and radiotherapy and chemotherapy. So this is the commonest primary orbital tumor in children, while the neuroblastoma, it is the commonest secondary orbital tumor in children. So this the commonest site or the commonest primary is the adrenal gland or suprarenal gland. These children will present with a sudden onset. Again, what the rapid onset is characterizing for the metastatic tumors, and the multifocality is again the characterizing feature of this of metastatic tumor. So they will present with bilateral ecchymosis, or what's called raccoon eyes. So both eyes are black. And when we did imaging, you will find there is multiple or different or multiple masses that involve both orbits, and they will be multifocal and causing bone erosions or bone destruction. This tumor can be also associated with the ipsilateral horn syndrome if the tumor is arising beside the sympathetic ganglion, and there will be a specific sign which is called opsoclonus, as we said before. It is carry a good prognosis, meaning that it is present with the saccades. So the patient has abnormal saccades, vertical and horizontal in all directions, that's present during awakening and absent during sleep, and this is called the opsoclonus. Sometimes the secondary orbital tumor are not from metastasis, but from local invasion from a tumor that is present in the orbit. So it is just an orbital tumor with a secondary orbital invasion. For example, if case of basal cell carcinoma. The basal cell carcinoma, if present with the medial canthus, it has a tendency to invade the orbit. Please note, it invade the orbit, not invading the globe. As you can see here, this is a tumor in the CT scan, and the globe is intact. So it will invade the orbit, not invading the globe. As it is called the rodent ulcer, so it has the tendency to erode the tissues. So patient present with a neglected basal cell carcinoma can present with marked down and out dystopia, as you can see here, with the tumor filling the orbital cavity now. So the management of this condition is variable. So there is no one-size-fits-all solution here. So if the tumor is small and localized and can be accessible with no distant metastasis, so if there is a small orbital tumor, then we can go for complete excision. However, if the tumor is large and extensive and but is responsive to chemotherapy and radiotherapy, so then we may expose the orbit to radiotherapy and give the patient chemotherapeutic agents. But if the tumor is invading the orbit and the eye is no longer salvageable, so there is no visual potential from this eye, so we may go and we cannot reach the posterior extent of the tumor by any method, so we may go for exenteration.